So moving on to the surgical criteria, which procedures are appropriate for day surgery? And you, as health boards, are already looking very closely at this. You'll know that way back in 2000, 2001, the Audit Commission produced a number of procedures that they thought were appropriate for day surgery. And it's interesting that up and down the country, even 18 years on from this, we've still got people struggling with the basic procedures on here. And you've talking yourselves about the lap choles and the tonsillectomies. Not all these are nailed yet. However, we're really moving on from that. We no longer want to say day surgery is just for these procedures. We're trying to say now that day surgery is for the majority of elective surgery, and we'll hear later, emergency surgery as well. And I think of it differently. I think, okay, what is it about a procedure that would stop them from being a day case? So the first thing is they have to be able to eat and drink. If the procedure means that they're going to need to be nasogastrically fed or have IV fluids, then that's not appropriate for day surgery. We have to be able to manage their pain with simple oral analgesia plus local anaesthetic techniques. And that local anaesthetic technique might even be sending them home with an interscalene catheter and local anaesthetic infusion, and some units do that, and a district nurse will go and take that out 48 hours later. So you can still be quite imaginative, but we can't send patients home with working epidurals, patient-controlled analgesia, intravenous morphine and the likes. Is there a low risk of significant catastrophic immediate complications? So again, if you're thinking that a patient's going to be very unstable post-operatively, then that procedure is not appropriate for day surgery. And will they be able to mobilise? It might be with aid, it might be with a wheelchair, it might be with crutches, but they do need to be able to get from car to chair to bed at home. And we've talked already earlier about what we do when we're trying to introduce a procedure to day surgery. We need to evaluate the short stay inpatient procedures that we're doing and look at the pathway and say what we need to change in the pathway for that procedure to allow it to be a day case. This was one of the big myths for surgical procedures, was that operations lasting more than 60 minutes shouldn't be a day case. However, Mark Skews, who's one of my predecessors as BADS president, looked at this, and he looked at the unplanned admission rate for longer procedures versus shorter and showed no statistically significant difference in unplanned admission rate. And actually the Americans then came along and said, you know, now it's really appropriate for surgical procedures lasting 3 to 4 hours to routinely be undertaken as a day case. And certainly as we're moving into the realms of hip surgery, knee surgery, nephrectomies, hysterectomies, most of these procedures are well over the hour. They certainly are with my surgical colleagues. So what we're saying now is that basically nearly all surgery should be day or short stay surgery. I think you're all really familiar with the BADS procedural directory, and that's fabulous. And these are the sort of procedures that we're looking at now. So we're not looking at your simple lumps and bumps. We're looking at nephrectomies, prostates, hysterectomies, mastectomies, and the like. So it really is pretty well everything. And this is how far we've come. You know, ophthalmology, you've already said here that you're looking at vitrectomies in some trusts, absolutely correctly. It used to be cataracts, it's now vitrectomies. Gynae, we used to worry about hysteroscopies. We've now moved most of those to the outpatient clinic under local, and we're now doing hysterectomies as day cases. Orthopaedics, we've moved from worrying about arthroscopies to unicondylar knees. We certainly have been doing those in Torbay for 6 or 7 years now. And the next big thing, and one of the speakers in Sheffield is from Hull and is talking about their day case total hip replacement pathway. And Northumberland are claiming to do 40% of their hip replacements as day cases. So, you know, people are really pioneering some pretty big stuff. Urology used to be circumcisions. Stoke-on-Trent and ourselves do nephrectomies now as day cases. Exeter are doing prostatectomies. So, you know, things up and down the country, people are really pushing the boundaries. I think this is really important. This is just some data from my own trust looking at our day case rates. And it's not really to show you how well we're doing, it's to say how important it is to know your own data. And however you produce it, it doesn't matter, but it's really important, I think, to have a run chart by procedure of how you're getting on. And that can be done by health board, by individual trust, by individual surgeon. Surgical colleagues are very competitive, and it can be quite a good way of stimulating teams to say, actually, this team are doing really well. What is it that they've got right that we can learn from so that we can get our rates up as well? We talked about breast earlier, and we were rubbish at breast cancer surgery as day case, and I was always mortified that we were one of the worst trusts in the country and we just could not get it cracked. And so we took our breast team to one of the healthcare conferences events where they were looking at day case breast cancer surgery. And we put a pathway in place, and every picture tells a story. You know, we went from being one of the poorest performers in the country to now we've got very respectable day case breast rates. So it just shows that you really can transform your services by looking at it, but you need to know where you've got a problem. Hysterectomies. This one's interesting. This is our laparoscopic hysterectomies. We also do vaginal, which we're now at pretty well 100% rates for day case vaginal hysterectomies. The reason our rates are so high is our surgeon who does all the vaginal work is an absolute zealot, and he makes the admissions staff, if anyone books one as an inpatient, they have to put the notes on his desk. He'll have a look and review and say, no, actually, of course, that can be a day case. And that's partly because there's only 2 of them who do them routinely, but sometimes they have new registrars who come in and who just don't know the pathway. And that just shows that if you get someone who really has ownership of the pathway and is prepared to support you, then that will help drive these things forward. So it's just a little example of how one person can really influence the process and make sure that we get the process right. And this is our unicondylar knee replacements, which I have to admit is a bit up and down all over the place, but I think you could believe that we're at 50–60% on average. So in summary, in terms of patient selection for day surgery, is the procedure in the BADS directory? Is the patient fit to have the surgery at all? Okay, how do we manage them as a day case? Part of the challenges were a particular individual, to be fair, who was resistant to change. The other big thing was the team just weren't used to it and weren't comfortable with it. And there was this sense that patients with breast cancer surgery are different and that they need to be in hospital because they're going to be very upset and they've got to be looked after. And there was a real paternalistic attitude to what these patients needed. There was concern about fitting prostheses, and there is a standard quality measure that the breast cancer surgeons are measured against about the fitting of the prostheses afterwards and the bras and everything that needs to go in place. So we worked closely. What was really good was the breast nurses were really engaged. So we got our day surgery nurses and our breast team nurses together. They then worked out what problems needed sorting. There was concern about drains and management of drains, and one of our surgeons still insists on using drains. So our day surgery nurses went and learnt from the breast care nurses about the management of drains, and we produced some leaflets about managing your drain at home. And I think ultimately we also shamed them into it. And our medical director said to me, you know, Mary, every month I have to sign off this red flag against day surgery rates for breast surgery. What are you going to do about it? So we started just reporting it and then got those who were keen to come along. Since then, our less enthusiastic surgeon has retired and we have appointed a second enthusiast, which is great. But a lot of it was about the nurses really being prepared to work together and say, there isn't a reason not to do this, and almost driving the team along. We just would very rarely book one as an inpatient. So I think it goes back to something we were talking about earlier. If you're trying to say, oh, well, this might happen and that might happen, and maybe we should book this one, or maybe we should reserve a bed for this one, then your chances of them being a day case are much lower. So we find there's very few that actually need to be booked as an inpatient. So our default is a lap chole is a day case procedure. And if they need to open, then we'll find them a bed. But really, the laparoscopic surgeons are getting better and better and more specialist. And they're managing to do more and more challenging stuff laparoscopically. So I have to say, we so rarely, yeah, I think it is. We so rarely open, and you know, if that happens occasionally, so be it. But don't try and second guess it beforehand, because you will talk yourself out of a lot of patients who could be day cases. I think one of the important things is that the message starts from primary care. So if you can ensure that your primary care colleagues, when they refer a patient up, they don't know that they're going to have surgery, but you know, I'm going to refer you because you've got a hernia and it's possible that surgery will be an option. And if it is, that's usually done now as a day case basis. So that the message starts there, because as soon as someone says, no, that's done as an inpatient, then the patient starts challenging, and then the patient will challenge the surgeon, and particularly if it's a less experienced, more junior surgeon, they might say, oh, well, you know, yes, if you'd rather be an inpatient, I'm sure that's what we can organise. So it's getting that message, but also getting the message to primary care that we are not dumping on them, and that we're absolutely not trying to do that, and that we will mop up our own mess. And that hopefully there won't be any mess to mop up, but that by moving all this stuff to day surgery, we're not just saying, there you go, it's your problem. So I think it's communication.